Hypopigmentation. Letter of referral. Dear Dr. Mr. Bikram Bhandari, age 35 years. Thank you for seeing this young Indian man who has noticed white areas of skin on the dorsum of both his hands that have been increasing in area over the past 6 months. He is anxious that it may soon spread to his face. Please see and advise. Yours sincerely. Introduction. Hypopigmentation is usually due to a decrease in melanin within the skin, which is either completely absent, depigmentation, as seen in vitiligo, or partially decreased, hypopigmentation, as seen in post-inflammatory hypopigmentation. The causes are best divided into those causing localized or generalized loss of pigment. Localized. Vitiligo. Post-inflammatory. Hypopigmentation. Pityriasis versicolor. Lichen sclerosis. Leprosy. Halo nevi. Ash leaf macules, tuberous sclerosis. Chemicals, e.g. hydroquinone. Generalized. Albinism. Hypopituitarism. Generalized vitiligo. NB. As with other skin complaints, the psychological impact of conditions such as vitiligo should not be underestimated. These problems are intensified in patients with non-white skin types, where the contrast between normal pigmented skin and affected areas is exacerbated. History of the presenting problem. When did the pale areas appear? There are some inherited causes of hypopigmentation such as albinism, generalized, and the ash leaf and confetti macules, localized, of tuberous sclerosis that are visible at birth or shortly after. Most cases of hypopigmentation are acquired. Areas of vitiligo are often first noticed in summer months when there is increased contrast between normal and abnormal skin. Where are the pale areas? The distribution is vital to diagnosing the cause. Vitiligo classically affects symmetrical areas of skin and may be localized or generalized. Pityriasis versicolor classically affects the trunk in small dappled patches. Halo nevi, as the name suggests, simply affect a circular area surrounding a mole. The mole may sometimes go on to disappear completely, leaving an area of depigmented skin behind. Hypopituitarism and albinism are both causes of generalized hypopigmentation. Leprosy can cause both localized and more generalized hypopigmentation. Lichen sclerosis most commonly affects the genitalia, but extragenital involvement also occurs. Was there an itchy or red rash before the skin became pale? Post-inflammatory hypopigmentation is a common occurrence. The patient usually remembers a preceding rash which looked different to the pale patches left behind. Lichen sclerosis is often pruritic. Vitiligo is characteristically asymptomatic. Other relevant history. General health. Is there any suggestion of hypopituitarism? Is there any suggestion of autoimmune diseases such as thyroid problems or pernicious anemia? Vitiligo has a strong autoimmune basis. Chemicals, drugs, and topical applications. Topical hydroquinone is used as a skin bleaching agent. Occupational contact with some rubber and photographic chemicals can cause skin hypopigmentation. Foreign travel. Has the patient visited or lived in a country where leprosy is endemic? Family history. A family history of autoimmune diseases may be present in both vitiligo and lichen sclerosis. Hypopigmentation examination. Cutaneous examination. Key points to look for include the following. Facial skin. Is there pallor of the periorbital skin? This is often seen in vitiligo. Nails. Look for signs of inflammatory skin conditions, e.g. psoriasis, pitting, onycholysis and subungual hyperkeratosis, that could leave post-inflammatory hypopigmentation. Hands. Is there pigment loss on the dorsum of the hands? Vitiligo often affects exposed sites, Fig 33. Is the skin dry, xerosis? Hypothyroidism is often associated with vitiligo and may present with dry skin. Examination of trunk and limbs. What is the distribution of the rash? Pityriasis versicolor may cause dappled hypopigmentation and or hyperpigmentation on the chest and or back, Fig 34. Pityriasis alba is a form of post-inflammatory hyperpigmentation secondary to mild eczema and is seen on the face, usually in children. Vitiligo is often symmetrical and distal in distribution. Hypopituitarism causes generalized depigmentation. Is the pigment completely absent or just paler than normal? Skin pigmentation is completely absent in vitiligo, but only partially lost in other disorders such as post-inflammatory hypopigmentation. Is the skin texture normal? Thickening of the skin sometimes occurs with post-inflammatory hypopigmentation, usually when scratching and rubbing of the skin has caused lichenification. Lichen sclerosis may cause thickening or thinning of the skin, Fig 33b. Is the rash scaly? Pityriasis versicolor is scaly, which can be exacerbated by gentle rubbing of the skin. Are there inflamed areas? Look for active areas of inflammation that may represent the primary lesions when hypopigmentation is post-inflammatory, Fig 35. Is skin sensation normal? Leprosy may resemble vitiligo clinically, but the patches are hypoanesthetic, test sensation to a pinprick, and often scaly. Further discussion. The causes of hypopigmentation are shown in Table 15. Causes of hypopigmentation. Clinical features. Vitiligo. Complete absence of pigment. Macules, well-defined edges, and no scale. Often symmetrical. Can be generalized. Post-inflammatory hypopigmentation. Partial pigment loss that is poorly defined. Occurs at sites of previous inflammation. Look for active primary lesions. Pityriasis versicolor. Dappled, scaly, and well-defined macules over the chest and back. Leprosy. Partial pigment loss, hypoanesthetic patches, and may be scaly. May be associated with enlarged palpable cutaneous nerves. Halo nevi. Complete loss of pigment in a well-defined area around a mole. Chemical depigmentation. Rubber chemicals via occupational exposure or iatrogenic hydroquinone can both cause leukoderma, clinically identical to vitiligo. Lichen sclerosis. White wrinkled cigarette paper patches. May have associated purpura. Classically affects genital skin. But extragenital lichen sclerosis also occurs. Hypopituitarism. Generalized hypopigmentation due to lack of MSH. Vitiligo is one of the most common causes. It has an autoimmune basis, and other autoimmune diseases that may occur in association with it include thyroid disease, pernicious anemia, diabetes mellitus, Addison's disease, premature ovarian failure, chronic active hepatitis and primary biliary cirrhosis. Halo nevi are a form of vitiligo where a ring of hypopigmentation appears around a pigmented mole, Fig 36. They are common in teenagers and young adults, and are completely benign. Areas of hypopigmentation occurring around or within moles in older patients may herald the development of malignant change within the mole. Plan for investigation and management. Investigations. Full cutaneous examination and relevant systems examination is needed. If leprosy is a possibility, palpate for enlarged nerves and test pinprick reaction to assess altered sensation in hypopigmented areas. Examine the skin with a Wood's lamp if hypopigmentation is subtle, looking for ash leaf or confetti macules. The Wood's lamp is a handheld source of ultraviolet light which fluoresces areas of epidermal hypopigmentation. Perform skin scrapings looking for yeast hyphae and spores if pityriasis versicolor is possible. Take a skin biopsy from an area of hypopigmentation if there is doubt about the diagnosis, to confirm lichen sclerosis or if leprosy is being considered. When relevant, check blood tests looking for associated autoimmune diseases in patients with vitiligo and lichen sclerosis, autoimmune profile, thyroid function tests and B1-2 levels, and a full endocrine workup if hypopituitarism is suspected. Management. Treat vitiligo. Treat leprosy. Post-inflammatory hypopigmentation, no treatment other than reassurance that it will improve with time. Pityriasis versicolor, topical azoles or oral antifungal agents such as itraconazole in widespread cases. Lichen sclerosis, avoidance of irritants such as soap, use of regular moisturizers and treatment with superpotent topical steroids when required. Genital lichen sclerosis is associated with a 5% lifetime risk of squamous cell carcinoma in the affected skin. There is no increased malignancy risk at extragenital sites. Patients need to be counseled about this risk and appropriate follow-up in outpatients arranged. Further discussion. What is the diagnosis? In this case, vitiligo is likely from the history. The symmetrical distribution on the hands is very typical, but post-inflammatory hypopigmentation should also be considered. How would you manage this case? Vitiligo does not necessarily require active treatment. Reassurance that it is not harmful, the use of sunscreen to prevent burning of the affected skin and tanning of normal skin, and camouflage may be sufficient, particularly in white-skinned patients. However, the psychological impact of vitiligo in brown/black-skinned patients can be devastating and active treatment is often sought. Topical corticosteroids or tacrolimus and phototherapy are used, but no treatment is necessarily fully effective.